I'm very enthusiastic today to talk to you a little bit about active disinfection with emphasis on the EndoActivator. When we choose a disinfection method, it should have evidence-based science to support it and be corroborated by various universities internationally. 2, it should be easy to use. And 3, it should be readily affordable. Certainly, the EndoActivator fulfills these 3 criteria. Well, the EndoActivator is a cordless device. It was the first device in the world to put a polymer below the orifice for disinfection. There are 3 tips to choose from among, and basically in the world of injection molding, we can say the small is about a 2002, we can say the red hub tipped is about a 2504, and the blue is approximately a 3006. We don't have the same tolerances within injection molding as you'll find in the machining world. So you have 3 tips that can be selected, and one of those will be snapped on the handpiece itself, and you can see the index finger can turn the unit on, and it will default to 10,000 cycles per minute. So the applications of the EndoActivator in the context of shaping canals with files and cleaning root canal systems is debridement, smear layer, and biofilm management. However, in 2-visit endodontics, when one entertains the use of calcium hydroxide, we can introduce the calcium hydroxide into a shaped canal quite readily, but we can adapt it quite intimately to the dentinal walls and the internal configurations if we vibrate it. And in fact, wesa from ACTA in Amsterdam, the Netherlands, has proposed that it's probably impossible to remove calcium hydroxide from any root canal system without using ultrasound. So we can use the EndoActivator as an example to not only adapt but remove calcium hydroxide, which is used internationally widely in 2-visit instances. Well, when the colleague is going to use mineral trioxide aggregate, the EndoActivator is a very potent tool to help vibrate the mud into the field of action. So we need to carry the MTA from the bench into the tooth. We can use spinal tap needles of various gauges to do that. We need to carry the mud in to within about 2 to 3 millimeters of where we want it to ultimately be. And then we can use the activator at lower cycles per minute to readily adapt, just like you would move dental stone into an impression material using vibration, or in the world of construction, you would vibrate concrete or what we used to call mud around rebar so that you would get a very dense core inside the foundation that it was being poured into. And finally, in the retreatment game, we often are called upon as endodontist or general dentist that like to do these procedures. We're called upon to remove gutta percha, silver points, carriers, and paste fillers. And once we remove the bulk of these materials, there needs to be the appreciation that there's residual material and sealers left behind. And certainly these tips can be used in a solvent, and these solvents can be activated to remove residual materials in the retreatment situation. Well, the clinical protocol for the EndoActivator is quite simple. You shape your canal optimally in the presence of sodium hypochlorite. To me, a well-shaped canal needs to be minimally 6%, and obviously if you're making your foramina bigger than what I would advocate, but more like a 40, then you can get away with a 6% taper. What I'm trying to say is I'm bringing good news. Nobody has to be wrong on this. If you want to hold the foramen smaller in size, more like maybe a 25, quarter of a millimeter, then it's going to be important to have a fuller, deeper shape in the apical third. So both groups of concepts of people can be right. If you want a large foramen, you can have a thinner taper. If you want to keep the foramen smaller and as small as practical, you'll need a little bit more deep taper, and that way everybody can be right, and we can talk about now disinfection protocols. So I aspire to a shape, as I've said earlier, of minimum about 8, 9, or 10%. That would be what I would want. Recall, the ProTaper 2007 will routinely give an 8% deep shape because of the brushing with the shaping instruments. So we select the tip by choosing the tip that will fit passively to within 2 millimeters of the full working length. The tip needs to be loose so that when it's activated, it can actually vibrate and swing like a pendulum back and forth so it can accomplish its intended task. We would then take our irrigating syringe, we would vacuum out all the sodium hypochlorite from the canal, and the canal would have very little sodium hypochlorite left residual inside the apical 1/3. We do not need to use paper points. Just vacuum out the canals the best you can and irrigate with 17% EDTA and then activate that solution for 1 minute per canal. At the conclusion of 1 minute, vacuum and pull that reagent back out of the canal and top the tooth off with 6% sodium hypochlorite and vibrate that reagent for 30 seconds per canal. This is the protocol that has been designed by 5 Western European professors whose life work has been involved in disinfection. It took 2 years alone doing research that was unpublished to develop the protocol so that we would know exactly when our work was done and when we were successful at completely disinfecting a root canal system. So this protocol works. However, I recognize that many of you will use a variety of different reagents other than what I just identified. I identified shaping canals with sodium hypochlorite, and recall I identified my final rinse solution as 17% EDTA. But there's many that have come on the market recently, and they're getting a significant amount of marketing and advocacy, and various articles have been published already, all saying that you should be using one of these final rinse solutions. And what I'm basically saying is, regardless of which one you use, don't let them sit there passively like a big pool. Activate them with the EndoActivator. The EndoActivator is bagged. This is to fulfill our disinfection protocols, not only from patient to patient, but within the tooth itself. The tip is snapped over the end of the rocker arm. The instrument is turned on, and we go right into the tooth. Immediately in your mouth mirror, you're going to see a lot of bubbles. And this is kind of exciting because it is some inclination to you what might be going on below the orifice. But to really appreciate what's going on, just look in your pulp chamber. Once you pull out the instrument and let all the bubbles implode, and you're just looking at a flat solution just sitting there, you'll notice a lot of debris. And if you use the EndoActivator on every single canal for 30 days straight, what I hear from dentists all over the world routinely, this is a very low level of evidence I'm reporting, but it's called common sense. Sometimes common sense is actually more important than, quote, the hallowed grounds of sanctity that we call evidence-based endodontics. But oftentimes the solutions will be filled with debris, they'll be cloudy for sure, and this would represent to you, chairside, the debris that would have otherwise been left below the orifice. Think about trying to obturate and move your obturation materials against dirty internal walls. So as a very low level of evidence that's very potent, though, in reality, you can just look at your solutions in the pulp chamber and imagine what might be going on below the orifice. Obviously, I need to show you what goes on below the orifice. So in an animation, you can see the tip is held back short of the terminus. It's activated, and an activated tip serves to fracture liquids. And what this does at the fracture site is it liberates and creates bubbles. And these bubbles begin to expand because of heat and pressure. And when the bubbles expand and actually implode, each single bubble sends out 40,000 shock waves. So in a simulated canal, in a plastic simulation of a root canal system, you can see all these bubbles and how they will expand and ultimately implode and send out 40,000 shock waves. So the EndoActivator works on the principles of bombardment, and it's the bombardment into the lateral anatomy that cleanses out vital tissue and necrotic tissue and allows us to create space so we can move obturation materials into that cleansed space. I want to show you a higher level of evidence, and this is using radiopaque hypaque. This is a pharmaceutical product. It's been used in medicine for over 30 years. It was typically injected into the vasculature. It would perfuse through the systemic circulation, and cardiologists looked at hypaque to diagnose atherosclerotic conditions, occlusion, and blockages of the coronary arteries themselves. And it was a radiogram. It is water soluble. It has the same specific gravity as sodium hypochlorite. So it's easy to use clinically. It gives you a radiogram, and it's easy to flush out of the tooth because it's water soluble. And the only reason not to use it would be for any patient who had a sensitivity to iodine. Well, here's hypaque going into a shaped canal, and after 15 seconds, you can see it moving laterally towards the mesial surface of the molar, and it's going directly to a large lateral root lesion. This material then is flushed out, and we dry the canal, mix up sealer, and use warm gutta percha to mold gutta percha and filling materials into the anatomy. But after the protocol was finished, here is hypaque puddled on the cavo surface of the root, and now I can say it's flushed out, and here it is packed in the way that you're more typically used to viewing your post images radiographically. We'll look at an upper tooth just for fun. We've done this on hundreds of teeth. Hypaque can be used to look for ledges. It can be used to map the shape of the canal as it's progressing. But you look at this first bicuspid tooth, and you can see there's a large asymmetrical lesion. And after, again, about 15 seconds of the protocol, you can see hypaque starting to move laterally towards the cavo surface of the root. Following the entire protocol, there's hypaque moving perhaps as many as 3 to 4 millimeters laterally off the body of the canal that I was able to shape. This is flushed out, the canals are dried, and again, we can use warm vertical condensation to fill root canal systems. And this is the image you're looking at, the finished result. Pretty exciting. So the lowest level of evidence is you sitting chairside, looking in your mouth mirror, looking at debris coming up out of the orifices. Although that's believable and it's very tangible for any clinician, you're still thinking, am I disinfected in 3 dimensions below the orifice? The hypaque work doesn't show you histologically that the canals are cleaned. It just simply says that you know a little bit about how the exchange of irrigants occurs during activation using the EndoActivator. So to get into a higher level of evidence, we have to look at scanning electron microscopy, and Gregory Caron did a marvelous study, and it was published ultimately in the Journal of Endodontics. What makes this study extremely useful is it was one of the first studies, if not the first study internationally that was ever done on the MBs and MLs of mandibular molar canals, and the canals had to be curved. So the curvature had to be 30 degrees or greater. And nobody had ever really looked at disinfection results around curvatures. Classically, most disinfecting articles look at straighter canals, usually anterior teeth, preferably maxillary. So this was a groundbreaking research project, and you can see in this apical 1/3 around a significant curvature that's coronal to the image. You can see the deep bifidity, and both branches are clean. If you look at a little higher power, you can see the protaper shapes towards the right of this image. The concavity is the aspect of the canal where shaping occurred, but the teeth were intentionally sectioned and fractured so you could see that we could move final rinse solutions about 300 to 400 microns into the dental tubules off the shaped canal. This is very, very exciting, groundbreaking work that will change forever how we view disinfection. At 2000 magnification, Gregory was able to show cleaned and opened patent tubules around curvatures in the apical 1/3 of these mandibular molars. Fascinating work, and if we're ever going to bond below the orifice, we're going to need to be able to bond to predictably cleaned lateral walls. Well, Valerie Cantor and Emily Weldon, in their work at the University of Florida, they compared ultrasonics to sonics. And you can see in these 3 points that when she looked at remaining debris 3 millimeters from working length, the EndoActivator was statistically significantly better than ultrasonics and the control group. If you looked at the 3 millimeter level for open patent dental tubules, again, the EndoActivator was statistically significantly better than the ultrasonic group. What was really interesting is in some of the ways she split out the various groups, some of the groups were obturated. And the EndoActivator reagents, in other words, the EndoActivator activated the reagents, and in those groups, they were able to measurably fill more lateral and accessory canals as compared to ultrasonics. If you look at just 3 of her hundreds of samples, you can see in very representative work that in the control group at the 3 millimeter level, there was quite a bit of debris and matting, and hardly any of the tubules are even observed to be open. In the ultrasonic group at the 3 millimeter level, you can see a lot of opened and patent dental tubules, but still quite a bit of bacterial mat covering significant surfaces. In the EndoActivator group at the 3 millimeter level, you can see that there are the most open patent tubules and virtually no matting or debris was left. This was very, very exciting work because there is a lot of controversy between EndoActivator and ultrasonics, and I think a lot of the debris that is remaining in the ultrasonic group could be debris that was generated by the ultrasonic insert tip itself, like the EriSafe tip that is marketed by Sadillac. A great researcher from Nova Southeastern University is Sergio Cutler, and he likes to go down to Buenos Aires, Argentina, and he works with my dear friend Fernando Goldberg. And what they did is several hundred canals comparing various ways to disinfect root canal systems, and they specifically looked at the EndoActivator, and they looked at sections in the coronal, middle, and apical third, and I think these 3 samples pretty much tell you the story about the EndoActivator. And again, this was done in curved mesial canals of mandibular molar teeth. Another very, very interesting study. And our dear friend Marcus Hapasallo up in Vancouver, British Columbia, he has just invented 2-in-1 Q-Mix, where it's basically EDTA and chlorhexidine, and there's a whole new protocol emerging from that work. But again, what was common was the EndoActivator was used to activate the reagents, and you can see in his published work that appeared in the January issue of the Journal of Endodontics the various representative samples. Notice how clean they are. Notice how open the tubules there are. And these samples are free of pretty much any residual debris. Gulab Avala has been known, certainly internationally, but a huge name in Europe for his groundbreaking work on disinfection over decades. And he's at the Eastman, and that's an internationally famous school on many different levels. But he likes to look at biofilms, and basically in his conclusions, looking at the EndoActivator system and dynamic irrigation to remove biofilms in extracted teeth or ex vivos, you can see that automated dynamic irrigation using the EndoActivator system was significantly more effective in removing stained collagen from the root canal than manual dynamic and static irrigation. And also, he noted that the efficacy of the EndoActivator was improved using larger tip sizes with higher power settings. I didn't really go through this that much, but the EndoActivator handpiece gives you 3 choices on power, and for disinfection, we're using 10,000 cycles per minute, which is the highest power setting. The lower power settings were used more for vibrating calcium hydroxide and MTA in those situations. Well, if you look at my friend Mahmoud Torbinejad's work out of Loma Linda, him and his group basically looked at the EndoActivator to activate his solution, mineral, tetracycline, an acid, and a detergent. And this came to market as BioPure. So MTAD is BioPure. And one of the big pushbacks in the marketplace to colleagues readily accepting BioPure or MTAD as a final rinse solution was it had a 5-minute soak period. So this means after shaping the canal, the tooth had to be filled with MTAD or BioPure, and then we had to let it sit there for 5 minutes to achieve wonderful disinfection that he reported. However, changing one single thing, the only factor that was changed was how about using the EndoActivator and dynamically moving BioPure inside a root canal that was infected with E. faecalis. And what he noticed was he could reduce the digestion times from 5 minutes to 1.5 minutes just using dynamic irrigation using the EndoActivator. If you want to come to my website, I'd like to have you, as a friend, visit me. I have a lot of information, much more extensive on EndoActivator irrigation, what's going on around the world, who's doing the research, what's the thrust of their research, and some of the papers that have been accepted for publication but have not yet been published. And you can learn a lot more about the EndoActivator if you're so inclined. Just a little clinical break from the monotony of describing what I just described, but let's get a little bit of blood going here. But look at this maxillary right central incisor with the internal resorptive defect, and notice that it seems like we look at these teeth and we usually fall back to our previous experiences that it's a maxillary central incisor, it has one canal and typically one apical portal of exit. But after doing a little bit of shaping and after some dynamic irrigation, you can see literally what has been called the thrill of the fill. I think you have 6 portals of exit that communicate from inside the canal to the periodontal ligament space. And look at this maxillary first molar. When I finished treating this, it was a little interesting when I looked more carefully at the MB system in the straight-on view. It looked like to me in the straight-on view there might be below the orifice, far below the orifice, and more like at the subcrestal, there could have been the origination of another entire system. So I wanted the dental assistant to take the mesial view to throw those roots more apart, and here we go. In the mesial view, you can see the canals did separate, and really what you notice is Ruddle missed the MB2. But because of using dynamic irrigation, I was able to move reagent through millimeters and millimeters of uninstrumented canal, and that puff is at the end of that apical portal of exit. This begins to show you how forgiving the EndoActivator can be in helping us achieve our disinfecting goals, because we rarely would be knowledgeable about all the various permeations of complex anatomy that exists below the orifice, but dynamic irrigation makes us more than we were by helping us to exchange and clean into the lateral anatomy, and then using a thermoplastic obturation method allows us to pick this anatomy up to get higher levels of long-term results. And how about this maxillary right first molar? Look at those arthritic buccal roots. This is going to be a challenge. I can't even tell you, looking at the pre-op view today, exactly where that apex ends. But let's get in here and start working. I found the MB root to be enormously challenging. In fact, it was so challenging that I finished that particular treatment and closed the case and dismissed the patient for that day, because I had already expended about 2 hours on the access and just the MB root. But what's exciting is if you stay with it and the desire is strong, and you have some chair time, and you want to keep your word to your patient, well, you can look at this outer loop that anastomoses off the primary canal. I never even knew it was there. It reanastomoses deeper into the body of the canal I knew was there, and then there is 1, 2, 3, 4 puffs of sealer. There's 4 apical portals of exit. I never knew only one of those was there. I didn't know 3 were there. So again, dynamic irrigation allows us to clean into the uninstrumentable portions of the root canal space. And finally, on a second visit, we can have the patient back and treat the distal buccal and the palatal roots. I would like to make a closing remark about active disinfection. They usually say the future is upon us, and I will tell you the future is now. Never before in the history of clinical endodontics have we been able to do so much, so precisely, with such predictability. Active disinfection is that last frontier that moves us from good to great. NITI allowed clinicians to get the reproducible shapes. Three-dimensional obturation has been around for decades, but it's been more refined with technology. But what has been one of the limiting factors in the modern era is active irrigation. And if we want to get post-operative images that look like this, if we want to get closer to our promise to treat root canal systems, then you're going to want to think about active irrigation. And again, select a method that is easy to use, that is readily affordable. And now I'll close that link. The EndoActivator gives you a disinfection solution that costs you $1.80 per patient on a single-use polymer tip. $1.80. For less than $2, any patient would want to have the potential for you to clean the root canal system. And finally, I tried to show quite a bit of evidence in the time allotted to demonstrate to you that there is real science behind dynamic irrigation using a polymer tip inserted onto the EndoActivator. I wish all of you good luck in your disinfection procedures.